Okay, Chapter 27. Chapter 27 is the first chapter in the next section of the course. We finished up medical emergencies, and of course medical emergencies are the ill patients that we deal with, and we're moving now on to the trauma patient, which are the injured patients that we deal with. Trauma, remember, is as a result of energy. So burns, explosions, fall down, go booms, shootings, stabbings, beatings, all those sorts of things constitute trauma. A lot of people like trauma. People tend to think that trauma is everything that we do in EMS, and that's really fairly far from the case. We know that the most common call for emergent EMS services is for shortness of breath, and that's almost always as a result of a medical issue or a sickness or illness. So it's not all we do. People are like, oh, I never could do your job because of the blood and guts. And in reality, blood and guts is only about 5% of what we deal with. So bleeding, wounds, and shock, which is what we're going to cover in this chapter, is that bloody, gory, good stuff, as well as a couple of the following chapters, which will be a little more on the exciting side of things. With bleeding, wounds, and shock, there's a lot of it that is blown out of proportion because it's often very dramatic. Bleeding and wounds tend to be distracting injuries. So when we show up on a patient that's short of breath, yeah, they may be a little blue in the face, they may have a little edema. Nothing's really cool, fun, and sexy about that. But when you got blood running down somebody's face, I mean, that usually gives you a little bit more sense of an urgency. When in reality, if it's a small head laceration, they're going to have a lot of blood running down their face, and chances are good that they're going to survive just fine. So in reality, sometimes it's the things that are less sexy that are actually more critical. So of course we have our chapter objectives on 6, 16, and 17 in the text. A few of those for this chapter. We have the multimedia videos for bleeding control and shock management, a little slide video on shock. So the core concepts we're going to cover is recognizing arterial versus venous versus capillary bleeding, evaluating that severity of such bleeding, discuss controlling external bleeding, look at the signs and symptoms and the care of a patient with internal bleeding, and then the signs, symptoms, and care of the patient who is apparently in shock. So we'll start with a quick circulatory review. Remember, the circulatory system, or the cardiovascular system, is the heart and the blood vessels. And here shows a diagram with the major vessels that we're looking at and talking about. You have obviously our arteries are in red and the major veins are in blue. Usually where you have a significant artery, you also have a significant vein or two. So, I mean, just to look at this, there's almost a mirror image when you look at the heavier, thicker lines of where do you have something else. So, but remember, major arteries being carotid, radial, brachial, femoral, the aorta, of course, and usually there's a series of veins that coincides. So arteries carry that oxygen-rich blood away from the heart almost always. Arteries always take blood away from the heart, but almost always it's oxygen-rich. Remember, the one example that it doesn't fall under this is the pulmonary arteries. Pulmonary arteries actually carry deoxygenated blood away from the heart to the lungs to become reoxygenated. They are composed of thick muscular walls that allow for dilation and constriction. Remember, these are high pressure systems. So if we look at the picture on 619 in your textbook, you see an example of an artery versus a vein versus a capillary. And you can look at the differences in the thicknesses of the walls. And we have a very, very thick wall on that artery. because it has to keep under control a lot of pressure. Remember, the pressure within the arteries is monstrously high compared to that of the veins. Veins, on the other hand, carry oxygen-depleted blood, rich in carbon dioxide, back to the heart in most cases. Of course, it carries the oxygenated blood back to the heart in the case of the pulmonary veins. And there are a few other weird spots within the body in which there is a venous portal system in which it doesn't actually go back towards the heart, it kind of bypasses. So it's kind of a detour. They contain a series of one-way valves that prevent backflow of the blood, and you can see an example of that on that picture in 619. Basically allows blood to rush through with a little bit of a pulsation, but as it tries to surge back, those leaflets of that valve will come together and stop it, hopefully, from going backwards. And then, of course, we talk about capillaries. Capillaries being the very, very smallest, most microscopic blood vessels that we have. In some cases, capillaries are so small that a red blood cell actually has to kind of bend in order to make its way through. This is actually, though, the vessels in which the work gets done. And that's the exchange site for oxygen, carbon dioxide, nutrients, waste products, so on and so forth, both at the onloading site, whether that be the lungs or around the gastrointestinal tract, or at the offloading site, which would be all of the other cells within the body, whether we're talking toes and nose and earlobes and fingertips and whatnot. So they can get to be very small. However, the capillary beds are a very, very vast network of small capillaries that kind of weave in between major areas and sections of cells, and that's where most of their work actually gets done. Capillaries are very thin blood vessels. The walls of the capillaries sometimes are simply a cell wide, cell thick, and capillaries often are referred to as a fenestrated vessel, meaning that they can open up when they dilate to a large extent. They start to leak a little bit because the cells kind of get spread out, and that leaves some gaps in between them, kind of like the Chinese finger cuffs again. If you press a Chinese finger cuff or Chinese handcuff together, you get these spaces that open up in between, and that mimics the walls of a capillary quite a bit. So remember, the functions of the blood are to transport gases, both oxygen and carbon dioxide in most cases, and a few other cases it picks up some other gases. Really, if the gas is able to get into your lungs, there's a good chance that it might get into your blood as well. Your blood also carries the nutrients, so the glucose, the vitamins, minerals, proteins, fats, so on and so forth, carries that throughout the body to the various places in which it can be put to use. And in some cases, it's put into storage. It's responsible for excretion, so it picks up, as it's swinging by a cell, dropping off sugar, dropping off oxygen, potentially, giving a little of its water away. It's also responsible for picking up the waste, so the lactic acids and any other spent materials that have been used by the body can then be picked up by the blood and transported to their various other points that are going to be taken care of, whether that's into the liver for something to be processed by the liver, if it's to the kidneys in order for it to be removed from the body, or maybe it's to the lungs, where the lungs will work on exhaling that carbon dioxide or whatnot and bringing in the oxygen. Blood, the often forgotten about part of blood, is the protection part, where blood also has the white blood cells, the leukocytes. Those leukocytes are responsible for fighting off the various antigens that get into our body, whether that's bacteria or viruses. Sometimes it's fungi, protozoas, some other kind of weird things that get into our body, as well as when we have allergic reactions. A lot of that is carried within the blood. And then, of course, regulation. And regulation has to do with maintaining body temperatures, maintaining a homeostatic environment, whether that's bringing extra water around. Maybe it's the kidneys, working with the kidneys, and the kidneys are controlling different nutrients and salts. So to put perfusion and hypoperfusion in a very simple diagram here, when you have inadequate blood circulation throughout the body, you have perfusion. Inadequate circulation to the tissues, the end organs, results in hypoperfusion, or what lay people call shock. And it's also a relative term. You have to consider hypoperfusion or shock to be relative, because if we say most of us have 6 liters of blood in our body, it is possible for us to be in shock and still have 6 liters of fluid or blood in our body. The way that would occur would be in the cases in which you have, say, a spinal injury, and the spinal injury stops feeding signals to the blood vessels to tell them what size to be. So since they don't know what to do, they just all decide, okay, well, let's just relax. And if everybody relaxes and all those capillaries, all those veins, all those arteries expand below the level of the injury, we maybe will end up with a pipe or a tubing system that's capable of holding 9 liters as opposed to the 6 liters that we have. We didn't lose any blood, we just lost the capacity to move the blood for the simple fact that all the pipes just got too big. I would like for you to think again about, most of us are familiar with at least the different sizes of hoses that there may be on a fire truck, and some of these hoses are 4, 5, 6 inches in diameter. And so when we're talking let's say a 5-inch fire hose, and we compare that to a 3/4 inch garden hose, imagine trying to water your lawn or water your garden or wash your car with a 5-inch garden hose, a 5-inch fire hose attached to your 3/4 inch spigot that's coming out the side of your house. Would you ever get water out the other end of that hose? Yeah, you would. You eventually would get water, but it would be such a fine trickle that you would get no pressure. And we know that in cases in which we're trying to wash something or water something, we tend to need pressure because we need to move this water over a vast area. So it would be the same sort of thing. We just never can fill the container, therefore we can never get the pressure to do what we need to do. So let's talk bleeding. 2 major types of bleeding, internal and external. We often think about the external bleeding. We tend to forget about the internal bleeding. However, in many cases, the internal bleeding is much more dangerous than the external. So just to kind of compare the different types of bleeds, this is kind of a rough description. It's not a 100% always. There's no hard and fast rules, remember. So when we look at bleeding from a capillary, it's a slow, even flow. Usually it's a darker color blood. It may be steady, may be so slow that we dab it and we think, oh, it's done, and so we stop, and 30, 60 seconds later, oh, there's another little bubble of blood again, another drop of blood. It can be that slow in this capillary. Any of us who have ever had to do, well, any of us, period, have had a capillary bleed at one point or another, whether it was something we did while we were shaving, or we were a kid running or riding a bike or skipping or something like that, and we skinned a knee or we skinned an elbow. That's all usually capillary bleeding. You get this bleeding that just really is more of an annoyance than anything. Then we can move to venous bleeding. Venous bleeding is generally a steady flow. It's usually dark red in color. It's from a deeper laceration as opposed to more of a scratch or a scrape gives us, in most cases, a capillary bleed. We get a little bit more depth, a little bit into the tissues more, and we tend to see venous bleeding. A lot of times when people get a laceration on their head, it's a venous bleed, and it bleeds a lot. It bleeds heavily, and it's usually pretty dark blood. One thing that you can keep in mind about the human body is anywhere that you grow hair, or at one point or another should be or did grow hair, there is a significant blood supply. And that significant blood supply means heavy bleeds that sometimes appear out of proportion to what they actually are. Many, many times I've dealt with patients who had, half their hair matted to their head from blood, and you would swear that somebody scalped them, and come to find out they have this half-inch little cut. It's kind of deep into their scalp, but it just continues to bleed and bleed and bleed and bleed and bleed. And they're a little harder to control because they're not always as easy to see. And then we get to arterial bleeding. Arterial bleeding is a spurting, bright red, pulsatile flow of blood. So anywhere in which you can get a pulse, obviously you should be concerned with the potential for an arterial bleed. Also think that there are some other places in which you might be getting a throbbing or a pounding, such as some places around your head, like your temples. There's a temporal artery that runs right along there. Probably one of my coolest arterial bleeds I've ever had to deal with was somebody who basically scalped themselves from the accident that they were in, cut off a large chunk of skin from the side of their head, took off a significant portion of their scalp, and nicked that temporal artery, and had blood squirting straight out the top of their head. Or at least it appeared that way. It actually was right in front of their front and just above their ear a bit. So arterial bleeds can be life-threatening. In most cases, we get kind of concerned because you lose blood quickly via an arterial bleed. Venous bleed may be still, arterial bleeds are definitely the most dramatic of them. Venous bleeds can still be quite dramatic, very distracting, but they tend not to be quite as big of a deal. And sometimes we have injuries where we have all three, arterial and venous and capillary bleeding. Now, just because blood is not spurting or squirting, spraying out of a wound does not mean it's not arterial, because sometimes things come into place. Maybe there's a piece of foreign material in there that's preventing it from squirting. Maybe the way that the injury occurred, that it kind of came in at an angle or from the side, and it actually did nick the artery, but that artery can't directly spray out of that wound. So you have to pay attention to the flow. All right, so arterial flow can be the most difficult to control. It usually squirts with every heartbeat, whereas capillary tends to cut itself off. Venous usually is fairly easy to control. Things to keep in mind, though, is until you've held on to something for 5 minutes or so, you can't honestly expect that it's going to stop bleeding. And in most cases, when we're talking arterial bleed, we're holding on, we're pressing, and we don't want to let go for 5 minutes until we're fairly confident that it's started to clot off. So don't think that 30 seconds of direct pressure on something is going to be enough to control that bleeding. How severe is the bleeding? Is it exsanguinating hemorrhage? And if so, does it affect the priorities of treatment? So when we're talking about hemorrhage, and hemorrhage is the medical term for bleeding, and in many cases what we refer to as severe bleeding. So we have to look at the bleeding itself and say, is this really an issue? Is this really a problem? Is this something we need to be really concerned with? So we got to stop and look at that and say, how fast is that blood coming out of there? Is this something I can control? And if it's not, we may have to go on to other mechanisms. So our patient assessment for our hemorrhaging patient, obviously standard precautions. If you've got spurting, spraying blood, you probably should have full face protection on, a mask and goggles. And if you have a gown, it may not be a bad idea to throw a gown on because you're probably going to get covered in it. So monitoring respirations, opening the airway, ventilating. Remember A's and B's before the C's in this case. So we're monitoring, we're opening airways, we're ventilating if necessary, and in many cases it's apply a little bit of oxygen. If it's a severe bleed, we'll want to give them a little oxygen, kind of stack the deck. Our circulation is composed of checking pulses, checking the skin, color, temperature, condition, and controlling bleeding. If we don't do something about the severe bleeding, then it can lead to a life-threatening emergency. So some of our methods in controlling external bleeding. We have direct pressure. We sometimes also will talk about elevation. And elevation, it's not been proven to be of any benefit, but it really can't hurt unless you have another underlying injury to go along with it. So if you have a patient who has got a broken arm, then it potentially could be harmful. But elevating it sometimes makes it easier for us to get to, and using gravity to our advantage. Obviously, if the wound is below the heart, it's easier for blood to flow that direction. Pressure dressings. Pressure dressings can be helpful. Pressure dressing is different from a tourniquet. A pressure dressing a lot of times is something we've either wrapped quite tightly on there, but without traction. Or we also can consider some things like taking a blood pressure cuff and putting a couple of dressings over the wound, put the blood pressure cuff on, pump it up a little bit, hopefully it holds there, and allowing that to apply some direct pressure for us. Depending on where we work, we may also talk about a hemostatic agent. And hemostatic agents are different types of more or less chemicals that we can pour into a wound that will help coagulate or clot the blood. For fun, when you guys get done with this, I want you to do a YouTube search. Go on to YouTube and do a YouTube search for something called quick clot. You might want to put quick clot pig. But that quick clot pig video that they have taken a pig that's still alive, and as a demonstration for the military, have lacerated an artery, and there's an arterial spurt that comes from this thing. And they'll take this quick clot and pour it in there, and it stops the bleeding nearly immediately. And to spell quick clot, leave the C out of it. So it's Q-U-I-K-C-L-O-T. So leave the first C out of quick, or the only C out of quick. Quick clot, and pretty amazing video. So take a look at that. And then finally, tourniquets. We kind of have gone back and forth with tourniquets over the years in EMS. Tourniquets were good, tourniquets were bad, now tourniquets are good again. Basically, the original thought was if we leave a tourniquet on for too long, then a person loses a limb. That is true. However, they've come to find out scientifically that we're talking many, many, many hours that tourniquet has to be on before they lose a limb. Mind you, a tourniquet is not fun. Nobody's going to love the tourniquet that you put on, at least at the time you're applying it. But a tourniquet is sometimes the only method we have. So let's talk direct pressure. A direct pressure is applying firm pressure to the wound with a gloved hand and a gauze bandage. And actually that's a misnomer right there. It actually is a gauze dressing. A dressing is what you put on the wound. A bandage is what holds a dressing. So if we talk about a Band-Aid is actually both. The white little gauze square on it is the dressing, and the skin-colored or the flesh-colored adhesive plastic strip is the bandage. So dressings touch the wound, bandages hold dressings. So it's applying firm pressure with a gloved hand to the wound with a piece of gauze. Sometimes it's simply with a gloved hand. On a rare occasion it might be without even a gloved hand. But hopefully it's something that we've got something that can can be used to soak up some blood and then hold the pressure, of course. We're going to hold this pressure until bleeding is controlled, and when necessary we add dressings when the lower ones are saturated. Now, this is one place I think you should stop and use a moment of critical thinking on this. We think about the old fairy tale of the princess and the pea. We know that there was a pea under the mattress and only the princess would feel it. That kind of gives us an idea that obviously not everybody was going to feel that because there was too much padding. Well, if we get too much padding between a wound and the direct pressure, we really lose the advantage of the pressure. It gets spread out and it gets dampened. So if you have saturated dressings, and let's say you have 10 4x4s between your hand and this person's wound, if you have 4x4s that readily come off of there, pull them off of there. If there's some, the one that's directly touching the wound, you maybe don't want to remove because there's discussion on whether or not you may disrupt a clot that's starting to form. But don't put 400 4x4 dressings over a wound. You're losing the advantage there. So take out what you can easily take out. If it feels like it doesn't want to give, then stop. Leave it alone. All right. So never remove bandages even when the bleeding is controlled. When we get that, and I don't like that never, but if we get the bleeding under control, leave the dressing in place. Because again, like I said, there may be a clot that has started to form there. And then when controlled, check the pulse distal to the wound. So if we put a dressing on somebody and we've wrapped it with gauze, it is possible for us to wrap it tight enough that it actually creates a tourniquet effect and cuts off circulation. If we cut off circulation, then the whole limb is in danger. But again, that's within reason. Usually we're talking hours. So elevation. They used to really push elevation. They used to push pressure points in which you'd find an artery, you'd press really hard on that artery to reduce the bleeding. Well, they found pressure points don't work. And elevation has just not shown as much favor as it used to. To be honest with you, a lot of things in medicine were started because they sounded good at the time, and they weren't based really off of a lot of factual scientific data. But elevation, there is some correlation to gravity and how quickly you bleed. So elevation hasn't been completely ruled out, but it's not nearly as important as it used to be. So elevation, we're taking that injured extremity above the level of the heart while applying direct pressure. Do not elevate if there's a musculoskeletal injury involved. So if you think they have a dislocation or a fracture or something of that extremity, don't do elevation. Pressure dressing. This is placing some gauze pads on a wound and then holding it very tightly in place with either a self-adhering roller bandage. Sometimes it's a blood pressure cuff. Sometimes it's just some tape really wrapped on there tightly. And the dressings are generally going above and below the side of the wound. So instead of us taking a 4x4 for direct pressure, taking a 4x4, putting it directly over the wound and taking 2, 3, 4 fingers, pressing directly on that wound itself, we might say we're going to take these dressings, we're going to cover an area, an inch or two above and an inch or two below the site, and we're going to really wrap that sucker up and try to get that bleeding under control. That's a pressure dressing. It also helps reduce some of the blood flow to that extremity. Hemostatic agents. There's several of these on the market anymore. The big name you hear is the one I mentioned, the quick clot, but there are others. Hem stop, I think, is another one that's I've heard of recently. But commonly, this is either a dressing that contains this substance, so we might have a special gauze that has some of this chemical in it that helps trap blood cells and helps agglutinate them or start to create a clot. Sometimes it is a powder. So it can be a powder that's poured directly into a wound. and it can be wadded up. If it's the dressing, it can be wadded up, inserted into a wound, and manual pressure is always necessary. So even though you use the hemostatic agent, whether it's in dressing form or powder form, you still are going to apply pressure to get the wound under control. But so hemostatic agents are going to depend on a lot on your local system. Your medical director will definitely have some say in whether or not you're going to use hemostatic agents. They're not without risks. The original versions contained shellfish, and so there was a certain part of the population that really you couldn't use these on because they were allergic to shellfish. I think they've started to refine these chemicals a little more and made those a little safer. Another big problem that with the original versions were they created an exothermic reaction, meaning that they created heat as a result of what they were doing. And with this heat, it sometimes would cause some minor burns, but they're kind of interesting. And then finally we have tourniquets. Tourniquets can be used if the bleeding is uncontrollable via direct pressure, and obviously only used on extremity injuries, so arms and legs. We don't have a tourniquet that we put around the neck for head injuries. Obviously that would be counterproductive to maintaining a working brain. So we don't have major tourniquets that we can place around the body to control an abdominal wound. This is one example in this picture of a commercially produced device that can be used for bleeding control. This one, I can't offhand remember what they're calling this one, but it's a fairly easy device to use. Just kind of give you a quick update on how this works here. You've got the big green main body of the device there with the little half moon shaped or the half circle key that he's got his hand on there, and the red button on the one side. Well, you would take this out, you would place that body somewhere on the limb that was easy to access. You've got that pull strap that's coming out the other side on the bottom side of that person's arm there, and that just runs through kind of a little ring. And so you would put that ring up in the hook there, pull down tight on that strap, and when you pull down tight on that, it kind of self-locks. And then once it kind of self-locks it, then you start to turn the key, and that key will ratchet until the bleeding stops. And then once the bleeding stops, then you can stop turning the key. In this case, if you need to remove this device, then you press the red button that's underneath the medic's hand on the side of the body of the device, and it will release the key basically, or release the ratchet, and allow them to take the tourniquet off. That's really not something you want to do in the field. So once it's applied, we do not remove or loosen it. Add an attached notation to the patient alerting others, to the providers, that the tourniquet's been applied. And some people are like, oh, well, the patient's alert, and they'll tell them, oh, yeah, I've got a tourniquet over here. Well, number one, patients don't know what tourniquets are. Number two, what if the patient goes unconscious? So as cruel as it may seem, we generally will take a marker, if we have it, and we'll write on the patient's forehead TK, the letter T, the letter K, and then the time in military time. And that helps alert people, hey, you need to go look for the tourniquet that's on this person because maybe they're covered with a blanket. And two, that's when we applied that tourniquet. So that gives them an idea how much time they have left to work on this limb. So we need to make sure that anytime we apply a tourniquet, we let everybody in the medical system know. The doctor, we tell the nurse, we tell any of the other medics and EMTs, there's a tourniquet here, there's a tourniquet here. So is the current method of bleeding control working? Do you need to move on to the next more aggressive step? And then how would you evaluate this? Again, remember, 30 seconds of holding direct pressure doesn't control anything. Even most capillary, you cut yourself shaving. 30 seconds of holding pressure doesn't even control that, and that's a capillary bleed. So we're talking minutes. Sometimes we purposefully will poke a needle into an artery to gather blood gases. And if we do that, we have to hold that for a minimum of 5 minutes to make sure that bleeding's under control, because it's such high pressure. So if we haven't held pressure for 5 minutes, we probably don't really have a firm grasp on how bad this bleeding is. So because there are a lot of bleeds that will take the full 5 minutes to get stopped. So does that mean we can't be thinking ahead? Does that mean we can't do some direct pressure and some elevation and maybe a pressure dressing or maybe a hemostatic dressing within a couple of minutes? No, it doesn't. But we shouldn't be immediately slapping tourniquets on people and saying, well, I held it for 30 seconds, sorry, crank, crank, crank. Oh, yeah, I know it hurts, and it does. Anybody who gets a tourniquet on will tell you just how badly it hurts. So some other considerations for stopping bleeding. These are kind of backups. I shouldn't say backups. These are kind of supplementary. They help, but they really don't actively do a lot. Splinting and the application of cold. So in that picture on the right, they're splinting that guy's arm. The more that the muscles are moving around, the skin is moving around, the bones are moving around, the more circulation there's going to be in that extremity. So if we make it so they can't move it, they can't use it, they're not going to need as much blood, therefore they're not going to bleed as fast. Cold application. What happens when you're outside running around and it's cold out and you have no gloves on, you have no hat on? What happens to your fingers and what happens to your ears? They turn white. Why do they get white? Because blood shunted to the core because of the cold. If the blood stayed running actively through there, it would cool the body much quicker. So if we apply a cold pack to an area that's bleeding, we can help shrink some blood vessels. And then that garment that they're showing in the picture on the left there is called the PASG or the MAST. PASG is pneumatic anti-shock garment. The MAST or MAST, sometimes called MAST pants, is medical anti-shock trousers, or what originally was military anti-shock trousers. We stole it from the military. But those can be placed over the abdomen and the legs to help treat, it used to be to help treat shock. They are not really in favor at the moment, but they are very good at providing a broad immobilization of the lower extremities and a significant source of direct pressure for major bleeds across the lower extremities. These are very controversial. This is definitely something that your medical director and your system would have to make a decision on whether or not they're going to use. So a few special bleeding situations that we may deal with. Head injuries. If we have a head injury, we can have increased intracranial pressure, not direct trauma. So we have pressure building up in the head from bleeding inside the head, and in the case in which maybe the bones didn't break quite, maybe we tore an artery but didn't break the bones, those bones don't give and the bleeding continues and it builds up more and more pressure on the tissues of the brain. So stopping bleeding only increases intracranial pressure from the head. So in some cases. So if we have, say, a person who is bleeding out of their nose and out of their ears because they broke part of their skull or broke part of their, broke some blood vessels open in their brain, and if we stop that up, then the blood is trapped and it backs up and it puts pressure on the brain. So we kind of have to be careful when it comes to head injuries. We'll talk more about that in that chapter. Nosebleeds or an epistaxis. Epistaxis is my all-time favorite medical term because it sounds really cool and it really doesn't mean much. If you have a person with a nosebleed, most of the time that's as a result of trauma, but there are other cases, whether it's you got punched in the nose or you got a digital trauma, which somebody was fishing up there for something, or sometimes people with high blood pressure will develop an epistaxis, and then we're getting to the time of year in which air is very dry, so it can be a little bit more common to see some minor bloody noses. We have the patient sit and lean forward, not head back. Head does not go back. That makes blood run down the throat into the stomach, makes people nauseated. Apply direct pressure to the fleshy portion of the nostrils. So start at the top of the nose, work your way down. There should be kind of a nodey part right about mid-nose there where it gets a little thick. Usually right below that thickness, that node of the nose there, you'll get to the fleshy part of the nose. Put your fingers as close up to that bone as we can get and pinch those nostrils together and hold. And then keep the patient calm and quiet. The more active and wound up they are, the greater chance they are going to continue to bleed there. And you're just going to hold. You can take a cold pack and put it across the bridge of the nose. There's also some discussion on whether or not applying some pressure above their two front upper teeth can help. So basically kind of at the Cupid's bow right there below the nose, if you press real hard below the nose into the against the upper bony jaw, you can, or I should say the maxilla, you can sometimes reduce bleeding. Do not let the patient lean back, and if they become unconscious, place them in the recovery position or on their side and be prepared to suction. These things can bleed and bleed and bleed. Sometimes it is very difficult for us to maintain and to get under control. So, and we also have to think about what's the underlying cause of this. So bloody noses in many cases do need to go to the hospital just to be fully evaluated. So we switch gears now to internal bleeding. So we can have bleeding to our internal organs, damage to these internal organs, and large amounts of blood vessels can be damaged, and then we lose a lot of blood. And the blood loss commonly can't be seen. So severe blood loss can even result in injuries to the extremities. We'll take, for example, your femurs. You can lose 1 to 2 liters of blood per femur. You can lose 2 to 3 liters of blood with a fractured pelvis. So you can lose 1/3 to half your blood volume with one relatively minor fracture of your pelvis or your upper legs. So the thing about internal bleeding is we have to be suspicious of it. We have to look for other clues that it may exist. So maybe they're telling us, well, my stools are really dark and tarry. Oh, well, that's a sign of GI bleed. What's the overall cause here? What's going on? Maybe they have an elevated heart rate and a low blood pressure and an elevated respiratory rate, and they're pale and they're cool and they're clammy. Those are signs of shock. Well, why are they in shock? Got to go looking. Maybe when we did our assessment, we checked all 4 quadrants of their abdomen and it was tight as a drum. Felt like you could bounce a quarter off that baby. Well, why is their abdomen all firm? Is it full of blood? So we have to be on the lookout for it. We have to suspect it. Blunt trauma is a leading cause of internal bleeding. Falls, motor vehicle crashes, automobile and pedestrian collisions, blast injuries. So when you're in an explosion, there's actually about 5 different results of the explosion there, 5 different collisions that kind of occur. And some of those collisions include, or some of those injuries include, the air-filled organs within your body suffering the trauma from the shock wave, and sometimes they burst. So these blunt traumas can often lead to this internal bleeding. Penetrating trauma usually leads to external bleeding, but it's the blunt trauma. So you get whacked in the belly with a baseball bat or punched real hard, and it cracks a rib and punctures a lung and cuts an artery, and now all of a sudden you're bleeding into your chest. You fell down and you bonked your head, you bounced your head off the marble floor, and just so happened that you had high blood pressure and atherosclerosis, and we're working up some other issues, and you happen to take a lot of blood thinning drugs and so on and so forth, and now you're bleeding in your brain. So here's penetrating trauma. That one probably hurts a little bit. Piece of wood stuck into looks like a calf. So So gunshot wounds, stab wounds, impaled objects. When we talk impaled objects, we'll kind of get back to this again, but impaled objects, unless they're going to alter our ability to maintain airways or do chest compressions, they generally have to stay in place. So some signs of an internal bleed. Injuries to the surface area of the body. We'll stop for a moment and think about where your seatbelt goes. Okay, if you wear a seatbelt with a shoulder harness and a lap belt, where did those go? So we end up going on an unconscious trauma victim who was in a vehicle crash, and we show up and they've got this stripe that runs clear down their chest from their left shoulder all the way down to their right hip. And maybe there's another stripe that goes from their left hip to their right hip. And obviously in the pattern of a seatbelt. Well, anything that was under there potentially was injured or damaged. So that might be something to make us go, very possible. So we look for that. Maybe we found crepitus or crunchy ribs in a certain area. Maybe we found a big bruised, swollen abdomen, or a painful, swollen deformity, and their right thigh is injured and it's almost twice the size of their left thigh. Well, what's causing that? Well, there's really only two things that are going to cause that. Natural swelling from the injury itself, but what's going to cause it to grow in out of proportion like that is going to be the loss of blood in that area. Then bleeding from any of your orifices. And they list mouth, rectum, and vagina, but could be the penis, could be the nose, could be the ears. Any of those can be possible signs of internal bleeding. The bleeding's coming from somewhere. We don't see a wound on the outside. That should give us an idea that maybe there's a wound on the inside. We talked tender, rigid, distended abdomens, vomiting coffee ground emesis or bright red material, or black tarry stools, or defecating blood, or they're peeing blood. Instead of yellow urine, they have basically blood, a stream of blood coming out. Some pediatric considerations. Infants and children, they're very efficient in compensating. So if they're losing blood, they do a very good job of keeping their vital signs looking very good and dealing with it very well until they lose around half of their volume of their blood. When we think about adults, and particularly the older you get, the more this is true. As adults decompensate or they become unstable, it's generally a fairly steady path. So it's a downhill roll. So they started out really good, and they gradually are working their way down. When it comes to kids, in many cases, kids they maintain, they do very good, and compensate, and then all of a sudden they're just done. So instead of them rolling downhill, they fall off a cliff. They go from doing great to rock bottom. The potential for shock has to be recognized and treated before any telltale signs appear, and that's not a pediatric consideration, that's an everybody consideration. So if we're dealing with the potential shock victim or patient, if we're so strongly suspicious of it, we should be treating that already before things are starting to pop up. So if they've already got those signs and symptoms when we get there, we have to deal with that. But if we've got that patient that, this is a pretty good crash, or that was a pretty good fall, we should probably make sure and keep you warm, and maybe we should put you on a little oxygen as a precaution, and we should control any external bleeding and try to ward off shock before we even get there. So some cultural considerations to consider as well. Places to assess the circulation via the skin color. Nail beds and lips, the conjunctiva of the eyes, which is the pink inner parts of the eyelid, so you may need to pull their eyelid down a bit, the palms of the hands, and the soles of the feet. Those are places you can look for cyanosis or pallor, whereas people of certain ethnic origins with definitely the darker pigments, it becomes harder and harder for us to assess. The other thing about is a person pale? You need to know that person if you can actually truly make a decision on, oh yeah, they look pale to me. Maybe that's their normal skin color. So I like to ask anybody who knows them, how do they look to you? They look a little pale to you? Oh yeah, they do. They look pale. So our treatment of internal bleeding is really all supportive. It's oxygen, it's ABCs, controlling any external bleeding, treating them for shock, which we're going to get to, and then transporting to an appropriate facility, rapid transport. We have, particularly at the advanced level, kind of a mantra that we use when we're treating certain types of patients. With medical patients, we tend to stay and play. As a paramedic, I've got lots of cool drugs and whatnot that I can do. But even as a paramedic, I don't have a lot I can do for a lot of trauma patients. Medicine doesn't change a lot for a paramedic in trauma cases. There's a few added skills, but not much. So when it comes to trauma victims, instead of staying and playing, we load and haul or load and go. So we try not to spend more than 10 minutes on scene with a significant trauma patient before we get them on the road to the appropriate facility. Now, what's an appropriate facility? That all depends on the patient, and it depends on the system that you work in. So if you are working in the metro area, a patient who's suffered a severe injury and is going to probably need a surgical intervention, you're probably going to want to bypass a significant number of the hospitals, spend that extra 5 minutes of transport time getting them to the on-call trauma center for the day because they have the staff and the tools to deal with it. Now, somebody fell down, broke a hip, somebody was sliding into base and broke their leg. Those people do not need trauma centers. Those people generally need general surgeon, or in the case of you broke a leg, you may just need to be casted. Somebody who broke a hip, they're probably going to need a general surgeon or an orthopedic surgeon, but they don't need a trauma surgeon. So you can go to your non-narrated PowerPoint here and watch this video. We'll move to shock. So shock is the inability to supply the cells with oxygen and nutrients, and it is the inadequate removal of waste products from the cells. So I want you to imagine your life if A, you had no way of getting groceries or water, and or B, you had no way to get rid of the garbage in your house or get rid of your human waste. So it just had to continuously build up in your environment. How would those two things, either singly or together, affect your life? You're trapped in your house. You can't get rid of waste. You can't get in anything new, good, or fun. So how does that affect your life? And I think that shows you pretty easily how it affects the cell's life when they can't get the nutrients, they can't get the oxygen, and they can't get rid of the waste. So causes of shock. We really have three major causes of shock, and I like to also throw a fourth one in there because people who don't have the fourth item will be in shock just as well. So we have the pump, we have the fluid, we have the pipes, and we have the oxygen or the air. So if you can't get oxygen in, you're going to go into shock even if the other three things are working just fine. So when we talk about the heart or the pump, the heart can't pump efficiently, so therefore it's really backed up. It doesn't get the normal amounts of blood flow out. The body will soon start to suffer. Two, the pipes, the blood vessels, they can become too big of a container to fill up. Or it may be a fluid problem. So we've lost a lot of blood. We don't have enough blood to fill those pipes. And then that usually is from a result of bleeding, but it can also be from severe dehydration. So a lot of vomiting and diarrhea or burns, those can cause severe dehydrations. So those are the three major categories of things that cause shock. So the severity of shock, we really have three levels of shock people can be in. They can be in compensated, they can be in decompensated, and they can be irreversible. So when compensated, the body does some things to make up for what it doesn't have. So the body can say, oh, well, I know that I've lost some fluid, I know that my vessels are too big, I'm going to clamp down what vessels I can, I'm going to pump my heart a little harder, maybe going to take some deeper breaths, a little quicker, and I'm going to do what I can to make up some ground on this. So it's kind of like, you know, if you're running late to on a very important appointment, what do? Well, you might try to take some alternative routes. You might try to drive a little faster, so on and so forth. You're compensating. When you're decompensating, that's when we start to see blood pressures fall, and that's what most novices believe. Oh, well, that's when you're in shock, is when your blood pressure drops. No, you've been in shock for a long time after your blood pressure starts to drop. So, or before your blood pressure starts to drop. When you're decompensated, your body no longer has the capabilities of keeping up with that extra that it was doing to keep things stable. And then we will develop irreversible shock in some cases. The cells have been damaged. They're all starting to die off, and it's causing rapid death. So guess what happens to everybody who is in irreversible shock? Because it's irreversible, they die. So where do you cross the line from decompensated to irreversible? That is not clear. It's not clear for us in EMS. So it's clear when they're doing more diagnostic tests and whatnot in the hospital. It makes it a little bit more clear to them. But for our purposes, they're compensated or they're going to be decompensated, and once we're going to treat them appropriately. So kind of here's a little cycle here. There's an injury that occurs, this guy's fallen or whatever. Some things that we start to see is we know that the pulse increases, and that pulse increases to compensate and increases cardiac output. Blood vessels are going to start to constrict to help shunt some blood. This causes them to look pale and become clammy. Some of that clamminess comes from the skin being cool, but also the body's secreted a hormone epinephrine and norepinephrine, or adrenaline basically. And part of the side effect of that is some sweating. You usually will have an increase in respiratory rate. The body says, well, I'm pumping blood faster. I should make sure that the blood has as much oxygen in it as possible. That blood gets shunted away from the gastrointestinal organs and the extremities. And when you shunt that blood away from the gastrointestinal organs, it causes some nausea. And then decreasing blood pressure is a late sign of shock. So the body keeps up, it keeps up, it keeps up, it keeps up, and now it's starting to run out of gas. It's running out of gas. It's running out of gas. And now, wham, it starts to fail. And that's when you start to see the blood pressure dropping. So three major categories of shock that we have here. We have hypovolemic, cardiogenic, and neurogenic shock. There are other terms that get thrown around with these things. These are the major categories. Hypovolemic shock results from a decreased volume of circulating blood and plasma. This may also be called hemorrhagic shock if it is caused by uncontrolled bleeding. Remember what I said, it can come from dehydration, from burns, or prolonged illnesses. Either type is hypovolemic. It's only hemorrhagic if it's caused by bleeding. So hypovolemic shock just simply means I don't have my 6 liters to fill my 6-liter container. I have 4 liters, I have 3 liters to fill my 6-liter container. Cardiogenic shock occurs usually in people who have had some sort of a heart injury, an infarct. It's going to result in inadequate perfusion to the heart and decreases the strength of contractions. And the heart system may start to malfunction, causing the heartbeat become very slow or very fast or irregular. So in cardiogenic shock, think about the heart for just a moment. How does the heart work when it beats? Well, when the heart beats, the whole thing squeezes together, right? Kind of at 360 degrees, the whole thing squeezes in. And 360 degrees, the whole thing relaxes out and squeezes in and relaxes out, squeezes in and relaxes out. Well, let's say you've had a heart attack that's wiped out a significant part of your heart. Well, so maybe only 180 degrees or 270 degrees the heart can squeeze in, and that other 180 to 90 degrees worth of heart does nothing but just sits there. So it doesn't give it its kick, it doesn't give it its part of squeeze. So, I mean, even if you think about trying to, grip a baseball bat, if one hand doesn't work, you can put it up against the side of the bat, but can you really squeeze the bat? No, you can't. So it's kind of the same sort of thing. You'll lose a certain amount of that kick, and that's where the cardiogenic shock will a lot of times come from. Neurogenic shock, this is also sometimes called distributive shock because it's hard to distribute all this blood through here with these giant vessels. It results from inability to control the dilation of blood vessels, usually from a nerve paralysis. There's no blood loss, but the blood vessels are too big to control the volume of blood that they have. We don't usually see this in the field. This is usually something that takes a little while to set in. But if we did see it, in most cases it would be somebody from that had a significant back injury and perhaps had to even wait a little while before they could seek EMS. So signs or symptoms of shock. These are all pretty consistent. We see altered mental status. Maybe it's just being anxious. Pale, cool, clammy skin. In most cases, there is some of the neurogenic shocks in which you actually will have flushed red skin in certain parts of the body below the injury. And then nausea and vomiting, and then vital sign changes. Respirations go up, heart rates go up, and then eventually everything goes down. Blood pressure, heart rate, and pulse tend to go down. So care for shock, aggressive airway maintenance, high flow O2, ventilating them when necessary, attempt to stop the cause of shock if we can. Some of them we can't. Cardiogenic shock, there's nothing we can do anything about. If we have a patient that maybe has severe arterial bleeding, that's something we maybe can. If you're allowed to and your service uses them, you can apply and inflate the pneumatic anti-shock garments. A couple things about pneumatic anti-shock garments is you don't use it. You don't inflate the abdomen before you inflate the legs. You either inflate the legs first and then the abdomen, or you inflate them all three at the same time. Splint any suspected bone or joint injuries. We have a patient with a severe condition. We're going to use the whole body splint, which is the backboard, and then go back and splint what you can as you have time. Prevent the loss of body heat, so keep them warm, cover them up. Even though it might be summer, keep them covered up so they can control the body heat loss. Deliver that patient to the appropriate medical facility within the golden hour. The golden hour, sometimes that concept is kind of changing. But the thought behind it is we really would like to see patients be on a surgeon's table and ready to be cut within 1 hour of their injury. Not 1 hour of the time we picked them up, 1 hour of their injury. So a lot of times we'll talk about the golden hour and the platinum 10 minutes. Platinum 10 minutes is the amount of time we want to max out on scene. We don't want to have any more than 10 minutes on scene if possible, and hopefully have them to the trauma center within an hour. Be calm and reassuring throughout your patient assessment. Some places are still discussing whether or not you should elevate the patient's feet. If you need to and they're on a backboard, you can elevate that up usually about 8 to 10 inches, they'll say. That helps move a little blood towards the head. application of the PASG. This is not a quick thing, and they're actually showing it incorrectly. If you're going to put these on somebody, they can have nothing on underneath them. No pants, no underwear, no nothing. So if you're applying it to the patient, you got to make them naked. So you're going to position these under the patient. You're going to wrap these up around. There's an abdominal section. It's all done through Velcro. And then you have the leg sections, and it's like a giant blood pressure cuff is what this is. It's just a giant blood pressure cuff. There's these different hoses that hook to different areas. So you get it very firmly on that. The patient's on a backboard. You hook up all your hoses, depending on what your system is set up as. In step 4 there, he's playing with the valves. So you can open a valve that allows you to inflate one leg, then you can inflate the other leg, then you can inflate the abdomen. Maybe you open both of the leg valves at the same time and pump them up together, and then the abdomen. Or maybe you'll just leave all 3 of them wide open, and you just pump the whole thing up in one foul swoop, and pump all the sections together. You can see those valves a little better in the picture there, step 5. Look right towards the left edge of the picture. You see a white line on the valve cover there, and then if you look just a little up and to the right, there's another one. Those are those valve shutoff valves for those hoses. So if the white line is going with the hose, the direction of the hose, so those are actually turned off. So if they're in the direction of the hose, then you are able to push air in or let air out. And then once you've got them inflated to the point in which you need to recheck vitals. You may not get good pulses distally, so you may not get a good pedal pulse, but hopefully we see changes in their quality of their radial pulse, and then hopefully a blood pressure improvement. So here's a shock video, and we come to the chapter review. So almost all external bleeding can be controlled by direct pressure and elevation. Those don't work. Consider a tourniquet. Emergency care for internal bleeding is based on prevention and treatment of shock. There's not a lot we can do. They need a surgeon. Early signs of shock include restlessness, anxiety, pale skin, rapid pulses and respirations. And if it goes uncontrolled, then we may start to see blood pressure start to fall. Signs and symptoms may not be evident early. Treatment based off of the mechanism of injury can be life-saving. So if we have this person that looks like, man, I don't know how you survived that, we should probably be treating them for shock ahead of time, expecting it to be coming. So treat shock by airway management, ventilating as necessary, high flow O2, controlling bleeding, keeping the patient warm, getting them transported immediately, not dinking around on scene. So the circulatory system is designed to ensure an adequate perfusion for the body. Classifications of the hemorrhage is directly related to the type of vessel ruptured and the pressure within that vessel, whether we're talking arterial, capillary, or venous. Treatment of the external hemorrhage includes progression through the following steps: direct pressure, elevation, tourniquet, use of hemostatic agents when we have those available to us. Internal bleeding is impossible for us to evaluate. The most appropriate treatment includes rapid transport to a facility. If shock develops, if the heart fails, then blood volume is lost, or the blood vessels dilate, and the body can't deal with that. Signs of shock reflect the body's attempt to compensate it. The most significant treatment for shock is early recognition and prompt transport to a hospital for definitive care. So some questions for you to consider. What can I use for a tourniquet that will control bleeding but not damage tissue? When you are in a practical session, hopefully you'll have an opportunity to play with a commercially produced tourniquet and then also get an opportunity to improvise a tourniquet. So you can improvise a tourniquet with some triangular bandages, or what we refer to as cravats, and some sort of a sticker or something to apply the tension to those cravats. So when treating a patient with shock, what should I do at the scene and what should I do en route to the hospital? On scene, you do the immediate things necessary to get them packaged and ready for transport. Do the rest of it on the way. Obviously, you get a minor assessment in, but you do a significant portion of your assessment on the way to the hospital. So, is a patient with pale, cool skin, tachycardia, rapid, shallow respirations in shock, or just under stress? And how will continuing assessment help in making that decision? Well, a lot of these signs and symptoms look the same. How are you going to come up with your answer to that? Really, a lot of it goes with the history, what happened, and your mechanism of injury. So our critical thinking question is, patient has been involved in a motor vehicle collision. There's considerable damage to the vehicle. The steering column is and the wheel are badly deformed. The patient complains of a sore chest, and you note no external bleeding. Patient's vital signs are pulse of 116, respirators are 20, blood pressure 106/70. How would you proceed and assess care for this patient? Well, you have an elevated pulse, you have elevated respirations. The blood pressure is not terrible, but it also, a lot of it's going to depend on that patient and what's normal for them. You have a mechanism of injury that's throwing all kinds of red flags. You have a bent or broken steering wheel and a deformed steering column from a motor vehicle collision at a high rate of speed. You've got to suspect, strongly suspect, that his chest slammed into that steering wheel and caused that injury. And if there's enough energy to do that, you got to strongly suspect that he has got something major going on.